Hello. Thank you very much, Manon. This is a special time for me. I would like to thank CERBA RESEARCH, the opportunity that gives me to show which are the role of metabolomics in NASH clinical trial. I have three parts in the talk. In the first one, I would like to introduce you what is metabolomics. In the second, I will try to show a clear example of what is able to provide metabolomics to monitor drug activity. And finally, we will address always difficult topic, that is how to handle the placebo effect in these NASH clinical trials. First of all, metabolomics is really the last omic. It's a very powerful tool for precision medicine, since it's able to determine metabolites in different fluids and tissues. Only to have you an idea, we can measure we cannot measure yet. We have 4,200 different metabolites in serum. Only in serum metabolome, 50% of them are lipids. Then there are plenty of information to pick in this with this technology, and especially if you consider that this metabolic condition we are talking, this NASH, is really a mismanagement of lipids. Then I think it's a technology that provides a lot of very useful information in this condition, like we will see in a minute. To give a clear example, what is able to provide with metabolomics, here you have a conventional test. You have 5 lipids to measure. You have a single number. Then only with triglyceride, you see there that we have 3 different radicals to join as up to 65 different types of fatty acid. Then you can imagine that there is a lot more to know about the triglyceride. This is the number. We can measure over 100 different triglycerides in serum. Then this is the power of the technology. And we are going to base our message today in our experience. We have completed 15 different phase 2 trials in NASH with many different types of drugs, almost the whole range, from the very innovative drug to the very classical approach. And we cannot really give details about the drug or the company yet, but I can give you some ideas about what metabolomic is able to provide to these companies and to this drug. The way to understand metabolomics is very visual. You have here a heat map of a particular example of these 15 trials. You have 4 columns with the placebo, the low dose, the medium dose, and the high dose, a typical phase 2 finding study. Dose finding study. Then to read this is simple. Is red means increase, green means decrease, and what is important in the black? All the blacks you see here means a statistical significant change. Then you see here how the technology, this is a long list of metabolites, more than 400 metabolites are listed here. And you see how you compare placebo and before and after the trial, you see how you don't modify anything. You have no blacks here at all, only some gray, very, very minimal changes from the beginning and after the trial. You have in the low dose here how some changes appear, some greens. You see some triglycerides diminution. You see this is a group in which we measure triglycerides. You see in the low dose how things are going to change the basal status. It's a little bit more clear because you have highly significant changes in these triglycerides in the medium dose, and what you expect your drug do is to diminish triglycerides, not only the whole triglycerides species, but some of them very significantly, even triglycerides. You see at the bottom, you see also ceramides, a nice signal of activity. Have no activity in the placebo, very mild activity, if any, in low. Some activity appears in medium, high dose, a lot of activity. Then this is a first example to show that with this technology, you can prove the activity of your drug in the very critical lipid groups that are really important to reduce in NASH. We have a second example, a different trial, different drug. You see a very, very clear signal on this particular group of ceramides. You will see the importance of that in a minute. But I want to emphasize here that you can observe no changes in ceramides, even with a low dose. A small changes in everything is increased. Is in pink, no significant, but increase. You see how this group of lipids are really starting to decrease in the intermediate low dose. You see how nicely they diminish the concentration of ceramides very significantly in the dose C, and you even can show very, very nicely how your drug is reducing this particular group of ceramides, all of the ceramides we measure, and very significantly. This is, as I said, is another trial, another example of a drug doing a phase 2 trial. But in this particular case, I want to emphasize that transforming these changes in ceramides in the percentage of patients that respond lowering ceramide, we can really transduct this signal of lipids content into a percentage of placebo response. For example, you see here how placebo has no response, low dose very mild, B a little bit more, and the highest response is D. Then another second important message with the metabolomic, you can show not only the activity of the drug, but also you can see the responder rates and the pathways your drug is touching. Why ceramide? I've chosen this ceramide information because of there is a theory in which NASH is really starting because of some lipotoxin produced in the body. Among those lipid groups that are involved in the, let's say, starting of NASH should be ceramide. You have here a selection of some of the major papers on this topic, and there is many more that showing that if you reduce ceramide, it looks like you are doing something good for your liver. And then we are going to address immediately another important topics of the talk. That is, once you have proved that you can monitor the drug, you can even know how many patients respond to your drug, then what Metabolomics is able to do is a much better evaluation of cardiovascular risk than the conventional method. You have in the conventional method very few parameters, only LDL cholesterol is the parameter you use to reduce with different drugs, to not to go above 100, and at the end of the day, you will find 50% of the people who suffer a cardiac attack have a normal level of LDL cholesterol. Through NMR metabolomics, we can provide all of this information that are related with the cardiovascular risk, and all of that are related with inverse cardiovascular risk, with cardiovascular protection. I'm going to show what happened in our phase 2 trial. It's a real case, a different trial than the one in which you can see now how placebo are not touching the main lipids, and how your drug is modifying significantly most of the lipid parameters that are involved with cardiovascular risk. It's very important to know that the number of particles and the size of the particle are the ones who are really well established now, that are the needed parameter to explain why a patient with a normal LDL cholesterol has, in fact, a high risk of having an attack because of the size of the particle or the number of the particle. Then we are moving now towards the last part of the presentation, that is the placebo issue. Then we have already seen in many trials that the placebo is like a very powerful treatment, because you see there how placebo effect are able to reduce even heavy or strong biopsy findings. That is a big problem, because you have to overcome this amount of effect to show the activity of your drug. Then the placebo response is, even when you see major criteria on histology, disappearance of NASH without worsening fibrosis is very strong endpoint, and can be really achieved by placebo in up to 20% of the patient. You see here how the recent trial has this issue on the topic, and at the end, your drug has to overcome this effect. If not, it's a failure. Then what happened? What offers you metabolomic? Of course, you have to do major endpoint in your trial, and it's the one you are looking for to beat. But in this race, you have a tool in which your drug can see what is the action of the drug without this noise of the placebo. You see here 8 different examples on column number 1 to number 8. This is placebo after and before the treatment. And you see how in no single column, but in the 7, has any meaningful metabolomic effect. Then what is the reason is still not known, but the clear fact is in trials from 3 months to 1 year, the placebo effect that is really modifying the MRI or even the biopsy is not able to touch the metabolomic pathways. Then your drug is acting again itself, as we have just seen. In the column 7, you see in this column, even having a placebo effect, we don't know. We cannot explain this finding yet. But the change are clearly deleterious for the condition. It's not it's a change in your lipidoma that are pointing that you are worsening the condition, not improving. Then, to me, it's very important to have this tool in the drug development career, especially in NASH, in which we saw in a summary that this can monitor the therapy. This technology is able also to support the mechanism of action of the drug, as we have already seen. We can evaluate properly the cardiovascular risk. This is critical in this stage, because the patient in NASH is not dying because of the liver only. It's also is dying because of the cardiovascular risk. And I didn't put any example of the possibility to develop a tailored companion diagnostic, but it's something that the technology can offer also, and it's important to track the improvement of the condition. This is the message, and my final slide. I would like to show you how CERBA Research and OWL can really close the cycle, because together we can provide the whole information you need to do a phase 2-3 clinical trial, because we can provide all kinds of liver markers. You see how efficiently we manage the liver biopsy. We can control all the need you have in a central lab for a phase 2-3 clinical trials. Then we include metabolomics in all of these different needs. You really can manage the whole important technologies in a clinical trial. Thank you very much.
You said lipodomic changes are closely related with the improvement of MRI or transaminases normalization. How do you explain the benefit observed in the placebo group without any signal in the lipodomic signature?
Yeah, the first part of the question is a critical one. These changes we observe in the lipidomics linked to a drug activity, it was really well connected with the improvement of the clinical endpoints, especially with the transaminases diminution, even the transaminases normalization. The percentage of patients that normalized transaminases in the trial I showed you are the ones who really diminish ceramides concentration. And how to explain this is something, how to explain the placebo response. In this lipidomic change in the placebo, the absence of the placebo response in the lipidomics, to me, still need further studies, but it should be related like you change your life habits in the placebo arm and in the trial. To be part of the trial allow you to receive the best treatment, then you do the exercise, you do the diet, you improve your condition, but you are not touching any particular pathway. Then you are not modifying the metabolisms yet, at least in the period of time we have observed. You need more time doing things properly, like you do in the placebo arm, to obtain, let's say, important changes. And the contrary, you use a drug, the drug can touch this particular pathway, like is the ceramide synthesis, and you can get this lipidomic change immediately.
Do you see blood samples for identifying biomarkers as a new and better way to assess NASH and NAFLD in patients? And if so, which biomarkers would you highlight as important to look for?
This is a very hot topic, many possibilities to look for biomarkers. I think you cannot miss, in any case, all the fibrosis markers. They are the strongest ones. And of course, we suggest very strongly to develop a lipidomic profile, like a marker of the condition.
Okay, thank you. Here's our next question. Do you think metabolic profiling will be considered a strong data by regulatory authorities to support efficacy of a drug?
Not yet, but yes, it will be very, for sure, it will be really very important once we publish this package of trial I showed you in the seminar, because this will become part of the explanation of the activity of the compound. Now is a let's say is a secondary endpoint, exploratory endpoint in some cases, but after completion of these 15 trials and a new phase 3 trial coming, I think the signal is so clear that will become regulatory power.
Thank you very much for that, Dr. Ortiz. Here's our next question. I guess the variability of the technology is very high. How many samples per group do you need to get significant lipodomic changes?
Excuse me? May I repeat?
Yes, sure. I guess the variability of the technology is very high. How many samples per group do you need to get significant lipodomic changes?
Yeah, this is not, it looks like very, the variability of the technology looks important because we have so many metabolites. But our panels, we have working for more than 15 years already in the field. And the variability is not more than 10% in some lipid groups in each metabolites. Then at the end, with 15 to 20 patients per group is enough. Then it's a normal size phase 2 trial should be enough to show clear change when occurs. You see, when the changes are not there, the technology shows you very consistent data as happened in the placebo group. And you don't need more than 10 to 15 patients to show differences.